Side neighborhood. Yeah.
All right, is it okay if we get started, Dr. Heidecker? I'll start with your introduction.
Yes, yeah, sure.
Okay, we have a good quorum. So welcome everyone back to UCSF's Cardiology Grand Rounds. I'm honored to present today Dr. Bettina Heidecker. Dr. Heidecker is the head of heart failure and cardiomyopathy at the Charité Hospital at the Berlin University of Medicine, Benjamin Franklin campus. She completed a postdoctoral fellowship at Johns Hopkins University, in addition to cardiology fellowship here at UCSF, before returning to Europe to establish a myocarditis clinic at Zurich University. She accepted her position at the Charité in 2018. Her research interests include inflammatory cardiomyopathies, amyloidosis, biomarkers, and precision medicine. She has received multiple research awards over the course of her career as a clinician scientist, including the Paul Dudley White International Scholar Award and the Samuel A. Levine Clinical Young Investigator Award from the American Heart Association, as well as the J. N. Cohn New Investigator Award from the Heart Failure Society of America. She held the Miriam Lemberg Professorship at the University of Miami, and she is currently a member of the Board of Directors at the Myocarditis Foundation. And with that, Dr. Heidecker, welcome. I'm very excited to hear your talk, and I will hand it over to you.
Thank you so much for the kind invitation. It's a true honor to be back at UCSF, where I trained for fellowship and talk about myocarditis and the COVID-19 pandemic. These are my disclosures. So an overview of my talk, I will give some background on myocarditis, then I will talk about COVID-19 myocarditis specifically and about potential genetic predisposing factors. I will talk about vaccine-related myocarditis and future diagnostic tools for myocarditis. Some background. So this is an overview of viruses that have played a major role in myocarditis over the course of time. Early on, we already see enteroviruses play a role in Coxsackie virus, which is still a problem, in particular in the pediatric population, and can be very aggressive. Also influenza viruses, HIV, which is directly cardiotoxic, hepatitis C, and then, of course, in the last few years, SARS-CoV-2. We were very interested already before the COVID-19 pandemic in viruses in myocarditis. In particular, we wanted to evaluate if there are viruses that have not been described yet in myocarditis, and if there is still presence of viruses at the time when there's symptom onset. We use the technology that's called workup, which has been developed by the lab with which I collaborated at Columbia University. So I went there to analyze our samples. workup is a technology with which we can analyze all known viruses and their potential variants, mutations, and can sequence them all at once in a patient. And it achieves the sensitivity of RT-PCR, which is different from general sequencing analysis. So that's a big advantage. We analyzed plasma, PBMCs, and myocardial tissue from our patients. And we were in particular interested in giant cell myocarditis. As you can see here, this is a giant cell which is characterized by a confluence of cells, macrophages. And this is a phenomenon you can also see in herpes virus infections. So for a long time in giant cell myocarditis, it was suggested it could be either autoimmune or viral because of this phenomenon. So we looked in particular also at those samples. When we screened for all viruses, we didn't find any, neither in the giant cell myocarditis patients nor in the other myocarditis patients, except for those that usually persist throughout life, like herpes viruses, EBV. And what this suggests is that at the time when the myocarditis breaks out, the viral infection has already been cleared from the body. And what maintains the inflammation is an immune-mediated process, which explains why so far immunosuppression has worked in myocarditis, but antiviral medications never really had a breakthrough in therapies. So about the diagnosis of myocarditis, typically patients present with acute chest pain. Some patients describe a gripping chest pain where they say it feels like their heart is in the hand of somebody and then that hand presses together, a little bit different from the elephant sitting on the chest that most patients with ACS describe. They can have dyspnea, which we found in a study is more common in women. Fatigue, malaise, palpitations, syncope. We saw also that syncope can be a red flag for severe arrhythmias. We had some patients who presented with syncope and then later on were found to have VTs. Signs of heart failure. And all those symptoms typically occur 1 to 3 weeks after viral infection. That can be upper respiratory, but also gastrointestinal. So as a routine diagnostic workup, we typically use troponin, of course, which is in most acute cases elevated, especially the high sensitivity troponin. However, in chronic cases, it's often within the normal range. We also get a complete blood count with differential. This is important because we want to see if eosinophils are elevated. This can be suggestive for eosinophilic myocarditis, which is a very aggressive form that requires immediate treatment. TSH is important because thyroid autoimmune diseases like Hashimoto can be associated with myocarditis. Antinuclear antibodies, ANCA screening for vasculitis, and soluble interleukin-2 receptor to screen for sarcoidosis. It's not 100% sensitive, but it's part of a complete workup. On EKG, we may see ST changes. They may occur in a coronary distribution. This, the potential mechanism is that some viruses are known to infect the endothelium, which can lead to endothelial dysfunction and therefore coronary vasospasm. And then as a result, this coronary distribution of ST changes. Patients may have conduction defects and arrhythmias. On echocardiography, also the wall motion abnormalities may be in a coronary distribution. There may be pericardial effusion, decreased ventricular function, and valvular regurgitation. This is a typical EKG from a patient with myocarditis with ST elevations in 2, 3, and AVF, which results typically those patients being investigated with a coronary angiography first, which is the correct way to proceed. Indications for endomyocardial biopsy. There has been a lot of discussion about indications over recent years, but I think what all experts agree on is that endomyocardial biopsy should be obtained in cases where we expect that the results will change management. This is a lymphocytic myocarditis here, and this is an example of an eosinophilic myocarditis. So those situations where we expect the biopsy will change management is in cardiogenic shock or acute heart failure, because those often are aggressive forms of myocarditis that may benefit from immunosuppression, ventricular arrhythmias or high degree AV block. Acute myocarditis or chronic inflammatory in the context of peripheral eosinophilia. That's the one that I mentioned, why it's so important to get complete blood count with differential. And if there's continuous recurrent release of necrosis markers, so if there's chronic elevation of troponins, we should consider doing biopsy, or if AV block is present or ventricular arrhythmias. And also if immune checkpoint inhibitor associated myocarditis is suspected when the diagnosis has impact on therapy. You can also do an MRI, whatever gets you to the result faster. That depends on the center. So either biopsy or MRI. Immune checkpoint inhibitor myocarditis, I don't need to tell you much about this. You recently recruited the expert, Professor Mosley, to UCSF. So you've heard, I'm sure, all his studies, but two important points I would like to make from his findings is that it's a T-cell mediated disease that responds very well to steroids, has to be diagnosed early because it can lead to severe conduction blocks, severe arrhythmias, and death. And also what is important to note is that typically it occurs within the first 30 days, but it also can occur later. So only because a patient tolerated the checkpoint inhibitors well at the beginning doesn't mean he may not develop myocarditis later. So always stay suspicious if they suddenly develop chest pain or symptoms during therapy. Giant cell myocarditis is another very aggressive form of myocarditis that requires immediate treatment. The recommended treatment is high-dose steroids, cyclosporin or tacrolimus, and possibly adding azathioprine or mycophenolate, and in very severe cases, ATG. Also, it's important that there is the option to provide mechanical circulatory support. So if a hospital in the periphery does not have that, it's recommended to transfer those patients early because they can very quickly go into irreversible multi-organ failure. I would like to put some weight on sarcoidosis, another form of inflammatory cardiomyopathy or myocarditis that does not present as fulminant typically, and I think that is why it's often missed. Many patients that present to us had already symptoms for several years, up to 9 years, and went to multiple experts, and often the MRIs showed some LGE, some inflammation, but could not really identify the sarcoidosis. And we really choose PET-CT for diagnosis if we suspect it. That's actually something I learned at UCSF. And this is a case that we diagnosed, a 37-year-old woman with right bundle branch block, left anterior hemiblock, and AV block 1, myalgias and arthralgias. And so all she really had were the myalgias and arthralgias. She didn't even have much chest pain, but this complex conduction defect made us suspicious because sarcoidosis typically affects the septum. So that's why they get conduction defects. And also they can get VT. So always when a young person has complex conduction defects or VTs that we cannot explain, we should think of sarcoidosis because this is the classic presentation. We treated her with prednisolone and methotrexate. So you see the course of time. This was in August 2019. 2020, there was still relevant activity. So ultimately with cyclophosphamide, it was completely suppressed. Another option would be infliximab. And with that, we usually get all patients in suppression. So it's really unfortunate if patients get into an end stage of sarcoidosis because we see it's very well treatable, especially even the aggressive forms we can treat with IV immunosuppression with the help of our rheumatology colleagues. So in the TIMIC trial, we've seen how inflammatory cardiomyopathy can be treated, also the lymphocytic forms. So there they used prednisolone and azathioprine and treated the chronic cases. So most patients with lymphocytic myocarditis, they usually heal spontaneously, but if they have symptoms for more than 3 months, then we should consider immunosuppressive treatment. And that's what this study has done. They provided prednisone and azathioprine for 6 months and defined responders as an increase of the ejection fraction more than 10%. And when they treated the patients, they saw 88% were responders, and those who were on placebo did not improve in their ejection fraction. And then they transferred the placebo group into the group A and ultimately treated 85 patients and did propensity matching with patients who were not treated. And now we have long-term follow-up data up to 20 years. And we see that the patients who received treatment with immunosuppression had less cardiovascular death compared to the controls and less heart transplantation. So those were the controls. So this is effective treatment. So we, in our patients also, if they have chronic inflammation, we start treating them. We've seen studies where CMR has been described as an important way to assess risk in myocarditis. So not only is it the non-invasive gold standard, but can also help in risk assessment. So in this study by Greni and colleagues, they had more than 600 patients that underwent CMR, and they saw that patients who had no LGE had relevant higher risk event-free survival compared to those that had LGE. And what was also found in that study was that if the LGE was in the septum, and especially at the basal septum, then the risk was in particular high. We also looked at LGE in our study, and what we also wanted to see is if LGE correlates with troponin and other inflammatory parameters. And we saw that this was not the case. And more importantly, we saw that when we did MRI 3 months after baseline MRI, even in those patients where LGE increased, troponins had normalized in the majority, and also the inflammatory parameters in the blood, suggesting that those markers are not sufficient to monitor treatment response or improvement of patients. If we are concerned about them, we should get a follow-up LGE. And this patient with this relevant increase of LGE from baseline to 3 months later, she actually developed VT that were hemodynamically relevant and needed to be cardioverted. So we also found that LGE is an important risk marker. So now to move on to COVID-19 myocarditis, there was a very relevant meta-analysis of PubMed and Embase reporting post-mortem cardiac pathology in adults who had COVID-19. They looked at 41 studies, including 316 cases, and they found that the deceased were mostly male, 62%, and above age 75. And amongst those, 1.5% had myocarditis. This is a case of myocarditis with COVID-19. This was a 37-year-old man. He presented with chest pain, dyspnea, diarrhea for 3 days. He had a blood pressure of 80/50, massively elevated troponin, more than 10,000, BNP was more than 21,000, and the 12-lead EKG showed ST elevations in 3 and AVF. On echocardiography, he had an ejection fraction of 27% and an LVEDD of 58, trace pericardial effusion, and as you see, large cardiac silhouette and pulmonary edema. So this patient was treated with methylprednisolone and immunoglobulin, and just after 1 week, significant improvement of the heart, the cardiac silhouette. We also see here the ejection fraction improved to 66%, pulmonary edema is gone, troponin down to 220, and BNP to 1,500. With this, I also want to point out the relevance of case reports. I'm sure this case guided many other physicians in the world. There were more than 800 citations already of this case report, and I think sometimes they are undervalued, but they really guide treatment when this is a new disease. So this is one point I wanted to make. So now I want to move on to potential genetic risk factors for cardiac injury. We had, at the beginning of the COVID-19 pandemic, we started this study where we wanted to evaluate why patients some only had mild symptoms while others had very severe disease. This reminded me a little bit of myocarditis, also the fact that men were more severely diseased with COVID-19. So there was this thought that there could be a potential genetic predisposition. So in spring 2020, where there was the first wave of the COVID-19 pandemic, we started this large international multi-center study with centers from Germany, Spain, and Switzerland. And we compared mild versus severe COVID-19. The definition of severe COVID-19 was patient got intubation or ICU treatment. And we looked at genetic risk factors. We were in particular interested in HLA alleles, since those have also been shown in other viral diseases to play a role in terms of the degree of severity, also for myocarditis that has already been described. So we recruited patients from the inpatient ward, the IMC, the ICU, the ER, and the outpatient clinic, the intermediate care unit, and the ICU, because we wanted to get the full range of the severity of COVID-19. And patients had to be over 18 years old, COVID-19 positive. That was confirmed with PCR from the nasopharyngeal swab or positive antibody test. We got venous blood samples and clinical data, and then we performed HLA sequencing and exome sequencing. We did validation in external cohorts from the US and in GWAS data through meta-analysis. We then did HLA affinity analysis in silico and a correlation analysis of the identified HLA with viral load and CRP levels, because our hypothesis was that HLA plays a role in the identification of the virus, and the viral load may be higher in patients who have the HLA that gives them disadvantage, or may have higher CRP levels because CRP is associated with a more severe clinical course. So these are our results. We had 435 patients where we performed HLA sequencing, and we identified HLA-C0401 as the allele that increased the risk for intubation with a relative risk ratio of 1.5 and an odds ratio of 3.5. This is within the German cohort that had 135 patients. This is Spain and Switzerland with 153 patients. And this is actually data from the COMET database from UCSF and also from Albany Medical Center. And there we had about 150 samples. And as you can see, dataset 1 and 3 where we found this significantly associated HLA-C0401. In dataset 2, interestingly, there was in Spain a majority of women in Sevilla that got COVID-19. That is unusual because usually it's 70% men who get it. So there must be some genetic difference in that specific cohort that may have masked the effect. But overall, in the meta-analysis, it was significant. And then we looked at GWAS databases that were available to us. And also here in this meta-analysis, we could reproduce that HLA-C0401 was significantly associated with severity of COVID-19. Actually, in more than 700,000 controls and more than 6,000 cases. We then went on to look at HLA-C0401 and susceptibility to COVID-19. So were there more patients who got COVID-19 if they were carriers of this allele? And that was actually also the case. There we had, of course, much more controls, more than 1.6 million. And we had more than 36,000 cases. We also wanted to look if there is a sex difference. First, we wanted to see if this allele is associated with cardiac injury. We didn't have enough MRI data to see if it's associated with myocarditis, but we did have troponin data to see if there's cardiac injury. And we adjusted for risk factors for coronary artery disease, of course. What we saw was that in men, if they were carriers and had COVID-19, troponin was actually significantly elevated compared to those who were non-carriers. In women, it did not have any effect. Also, we showed that troponin was associated with more severe disease, which had been shown by other groups as well. So now moving on to vaccine-related myocarditis. This is a consensus statement that we wrote with the ESC. The intent of this consensus statement was to put the incidence of vaccine-related myocarditis into perspective with the risk of getting myocarditis from COVID-19. Also to provide a guide for physicians on how to diagnose and treat myocarditis after mRNA vaccine, and to stimulate research in the area. This is just a short overview of studies that have already been done in this area. The most recent ones at that time. In the consensus statement, there are much more. These were the most recent ones that I'm highlighting here for you. What all of them show is that the majority of patients who get a myocarditis after the vaccine are men. Typically, it's between 70 to 100%. It's typically after the second dose of the mRNA vaccine, except in this one study in Denmark, where there were more women who got the myocarditis after the BioNTech vaccine. But overall, of all vaccines together, it was still men, 73%, who had myocarditis. The cumulative incidence was 1.7 per 100,000. And in the other studies, it was typically 0.58, 0.95 in 100,000 vaccines given. This was a study by Kaiser Permanente. This was one by Moderna. And those were large data sets. So here, 3 million individuals, more than 3 million, here more than 2 million. And in this Moderna pharmacovigilance study, even 151 million. So it's very reproducible. It's typically 0.95 in 100,000. And also in the more recent studies that have come out since our consensus statement, this keeps repeating. So this is really the data. We wanted to see why there could be this sex difference. This is a known phenomenon that has already been known for myocarditis overall. And therefore, we looked at our database at the Charité, and we had more than 6,000 patients with myocarditis, data that has been collected over 16 years. And we decided if we group them into age groups, we can get a better idea if the higher incidence in men is inherent because maybe of predisposition based on sex chromosomes, genetic, or if it occurs later due to hormonal changes. And interestingly, when puberty starts, this is when the sex differences become more apparent. So you have here the females and the males under the age of 11 in girls and 13 in boys. It's still more similar, the incidence, and then the older they get, it becomes more apparent, in particular at the age of 18 to 35 years. And then it becomes again less after menopause in women after 54 years, which is the average age for menopause. So there it decreases again. So this is data that we presented already. Meanwhile, we also looked at a database from the US. And through that, we had an analysis of more than 15,000 patients, and we find exactly the same. So that is currently under revision. So this suggests that this difference occurs potentially through hormonal changes at that age. So when we look at pathophysiology of vaccine-related myocarditis, it has been hypothesized that hormonal factors play a role. Testosterone is known to activate Th1, Th17 cells that may attack the heart. Also, the spike proteins may induce cardiac antigens and cross-reactivity with cardiac antigens. There's molecular mimicry that has been suggested, the autoantibodies that may be induced that infiltrate the heart, and the mRNA antigen by itself may activate CD8 cells. The diagnostic algorithm that we recommend for vaccine-related myocarditis is any patient who develops clinical cardiac symptoms. Typically, it's within a day of the vaccine, but up to 7 days is also still considered classic. Those should get an EKG, an echocardiogram, troponin, and NT-proBNP. And if that's abnormal, they should also get a cardiac magnetic resonance imaging. If there you find very extensive myocarditis, follow-up should be considered after 3 to 6 months. Typically, those are very mild cases. Also, if a patient presents with persistent symptoms after 1 or 2 months, still symptoms started after vaccine, and after 1 to 2 months, they still persist, it's also recommended to get a cardiac magnetic resonance imaging, even if those factors, EKG, TTE, troponin, are unremarkable. Especially troponin, as I mentioned, in chronic cases often has normalized, and there may still be inflammation in the heart. If there is clinical instability, we recommend endomyocardial biopsy. This is how the histology looks like in vaccine-related myocarditis. So here you see there's a dominance of macrophages. This is the staining for macrophages in the brownish color. And here you have the T cells, so much more macrophages than T cells. And that's also what you can find in COVID-19 myocarditis. So they present similarly. This is an important study that put the risk of getting myocarditis from the vaccine into perspective, comparing it to the risk of getting myocarditis from not being vaccinated and getting COVID-19. So this was a national study in Israel, very well designed, very well matched the groups, and each cohort had more than 800,000 individuals. And it was shown that the risk of getting myocarditis from COVID-19 was about six times higher than with the vaccine. And that they compared it in a way, as I mentioned, patients who were not vaccinated got COVID-19. They were compared with the vaccinated ones. Also, what you see is that other complications like intracranial hemorrhage, myocardial infarction, pulmonary embolism, and pericarditis were much greater in those who got COVID-19 than from the vaccine. This is a case of vaccine-related myocarditis that we've seen in clinic. A 21-year-old man with no significant past medical history presents with pleuritic chest pain, dyspnea, and one episode of fever of 38. Pain was alleviated by leaning forward. The symptoms started in the evening after receiving an mRNA vaccine. And on physical exam, his vital signs were stable. He was well compensated. Troponin was elevated, 391. NT-proBNP was 306. So this is the classic patient we've seen. They're not unstable. They often have fever and they have chest pain already the same day or one day after the vaccine. On EKG, he had ST elevations in V4 to V6 and ST depressions in 2 and 3. Coronary angiography showed no obstructive coronary artery disease. This was his MRI. So you can see the late gadolinium enhancement in the lateral and inferior wall. Ejection fraction was normal, 58%. He had anterior and inferior hypokinesis, subepicardial late enhancement. He was just treated with ibuprofen for his pleuritic pain, perimyocarditis. He had pericarditis type pain. He got ibuprofen, 600 milligrams TID, taper every 2 weeks, and that was sufficient. After 1 month's follow-up, he was asymptomatic, and after 5 months follow-up, we did a follow-up CMR. That was unremarkable. There were no more signs of myocarditis, and the blood tests had normalized. So future diagnostic tools for myocarditis. Long time ago, we've done this study as a proof of concept that RNAs may be a relevant marker for myocarditis. In this study, we looked at endomyocardial biopsies and we identified genes that were overexpressed in myocarditis compared to idiopathic dilated cardiomyopathy. Those involved toll-like receptor signaling and CD14, and that was also consistent with some prior studies that had been done. So then a very exciting study we contributed to is a study that looked at microRNAs to detect acute myocarditis. The methods were that first it started with an animal model where CD4 T cells and type 17 helper cells were analyzed in autoimmune myocarditis or myocardial infarction in mice to see if the microRNAs from those cells could be used as biomarkers for myocarditis. In addition, it was also done in Coxsackie virus-induced myocarditis. So there was an animal model with autoimmune myocarditis and one with virus. Then after the microRNA was identified, the human homologue for this microRNA that was seen in mice was identified. And then it was looked at several validation set if it can be used as a marker for myocarditis. And this was the initial data set where in myocarditis, this microRNA is elevated, while in myocardial infarction, it's also somewhat elevated, not as strong, and in healthy individuals, it's not elevated. And then there are 3 independent validation cohorts. This was ours with the MINOCA population and the myocarditis population, where it was significantly elevated. This was a validation set with biopsy-proven myocarditis versus myocardial infarction. And again, another validation cohort with myocarditis and myocardial infarction. So you see quite impressive areas under the curve, especially in the biopsy-proven ones, and promising data that this could be potentially used as an additional screening test. This is a proteomic study that you probably already know well, that I've done with Professor Peter Ganz. The study was, the proteomic risk score was developed in the Heart and Soul database with SomaLogic proteomic analysis, and the 9-protein model was identified in more than 800 patients with stable coronary artery disease, and then validated in the Hunt study, which is again more than 700 samples from Scandinavia. So this, what I'm showing you here, is already the validation cohort, and you see in dark the actual incidence of adverse cardiovascular events, and here's the predicted incidence. So you see across the deciles of predicted risk, it was very accurate in predicting risk, even in the validation cohort, in the independent validation cohort. So this may be also useful in myocarditis for predicting cardiovascular outcomes. This is a final research project I would like to present on magnetocardiography, a very interesting technology that I learned here at the Charité. This is based on the phenomenon that we all create an electromagnetic field in our heart. So not only we can measure the electric field with the EKG, but also the magnetic field. And in a healthy individual, the vector, the magnetic vector, points towards the left shoulder. And if the heart is diseased most likely due to change in ion flow, this vector, the sum vector, changes. And with this very highly sensitive instrument, we can measure that. So the patient lies here on that instrument. This is my research team that worked in this project. And in this DUA with this small quantum interference device, we can measure the magnetic field. There's helium inside that cools the inside down to minus 200 degrees Celsius. So with this, we achieve very high sensitivity. And here you can see the vector of a healthy individual. In a receiver operating curve analysis, we determined that in patients who are healthy, this vector score is usually less than 0.05, while it's elevated in patients with myocarditis, in particular in patients with acute myocarditis. So this one has, for example, a score of 0.014. That's a healthy individual. It's less than 0.05. When we look at patients who have myocarditis, like this first one here, this is another patient. You see here the late gadolinium enhancement in the lateral wall, which is typical for myocarditis. You see that the score is elevated. This is 0.178, and less than 0.05 would be normal. Also, you can see that this vector is much broader. This one is narrow. This is a broad vector. This is abnormal. And after 1 month of treatment, approximately, with immunosuppressive therapy, the vector had normalized. So this is already below 0.05. This is another patient who had also late gadolinium enhancement myocarditis, also had an abnormal vector, 0.195, normal is less than 0.05, very broad, and also in another quadrant. And what you can see is also approximately after 1 month of treatment, normalization of the vector. So not only Can we detect myocarditis with this instrument? We can even measure early treatment response. And the great thing about the technology is that it doesn't have any side effects because we're not exposing the patient to radiation. We're measuring the magnetic field that the patient produces. And also, it only takes 60 seconds. It's a very objective score. It can be learned very easily. It doesn't require seeing many images to be able to interpret this. We use this then to monitor treatment response in a larger population. And what we were able to show is that already after 7 days with the MKG, we can detect treatment response, significant response, while with the echocardiogram, it was only significant after 30 days. So in summary, standard diagnostic tests for myocarditis also apply for patients with COVID-19 or vaccine-related myocarditis. CMR is the non-invasive gold standard in myocarditis. EMB is indicated, endomyocardial biopsy, is indicated when results are expected to change management. Myocarditis is rare in COVID-19, approximately 11 events in 100,000, and even more rare after mRNA vaccine, approximately 2.7 events in 100,000. That's already a higher percentage from all the studies. The treatment consists of standard heart failure therapy and immunosuppression for COVID-19 and vaccine-related myocarditis. And tools for early detection are needed. Those may include proteomics, microRNAs, and MKG. And to the young fellows, I would recommend to become involved and find a purpose why you're doing research. For me, it was the Myocarditis Foundation who gave me my first research grant and were very involved with my research and invited me to a family meeting. And when I met the patients and their family members, and I realized how much hope they have in us in finding therapies and ways to diagnose the disease early. This really inspired me and kept me motivated. And this is Candace Moose, who is a transplant survivor after giant cell myocarditis, and she founded the foundation together with Leslie Cooper from Mayo Clinic. And they are very inspiring personalities. Also, they got me in contact with Steve Hilfiger, another transplant survivor who was diagnosed late with sarcoidosis, and because of that, started a campaign to create awareness about sarcoidosis, and we contributed to his documentary, which will be shown soon, about sarcoidosis. And my patients here, they actually contributed to that documentary. So this is really what's fun and really inspiring. And I recommend everyone to find an inspiration and a purpose. So with this, I would like to thank you for your attention and my many mentors. I cannot put all of them on my slides, but especially I would like to thank Peter Gans, who has been my mentor since the fellowship and always a great source for great advice and scientific input. My colleagues here in Europe, Professor Lüscher and Lammes, Leslie Cooper, Josh Hare, who's been my mentor since the very early days, the colleagues at UCSF who contributed to our HLA study, future collaborations, and my core team from the Charité, the ambitious students who did a lot of the work I've shown you. Thank you for your attention.
Thanks so much for that wonderful talk on myocarditis, Dr. Heidecker, and for also speaking with us all the way from Germany. I just wanted to point out. So if there's anybody who has questions for Dr. Heidecker, please raise your hand or indicate that you have a question in the chat so we can call on you. I had a question just with all you've researched about the post-vaccine myocarditis. How does that impact how you counsel patients and have that discussion with them about whether to get the vaccine or not?
I think by now that most of the patients had already 3 vaccines. I've seen a very interesting editorial in the New England Journal once by a vaccine specialist from Harvard, and he was recommending if you had high risk for vaccine myocarditis, if you had already your 3 shots, there's not strong evidence to get a 4th one. because the protection is for young people, because the protection is already pretty good with 3, and we don't have enough data to support that you need a 4th one if you're young and higher risk for myocarditis. Also had a patient recently, she had myocarditis after COVID-19. So for her, she actually took Paxlovid, and this time she said she felt much better. So I think this is important. If patients had already myocarditis after COVID-19, I would recommend to take Paxlovid because of it seems like the viral infection has a stronger immune response in them. So it's advisable to take that. Makes sense.
Great. And then Dr. Redberg, you had a question? I don't think we can hear you. It
Still on
still
mute.
seems on mute. If you want, you could also text me. It looks like Dr. Gans has a question. Maybe oh no. Yes, we can hear you. Yeah, we can hear you. It's a little faint, and there's a little bit of reverberation, I think, too. I don't think we can hear you quite well. If you want to maybe text me the question, I can ask on your behalf, or I don't know why, but the sound isn't coming through. So why don't we move to Dr. Gans if you want to ask your question, then we'll circle back to Dr. Redberg.
Yes, Bettina, I don't have a question, actually. I just wanted to congratulate you on a phenomenally good presentation and really the body of work that underlies it. And you and I talk pretty regularly since you left the program 6-7 years ago. And I know the ups and downs that are involved in any new career. There are faculty members who welcomed you. There are faculty members who were opposed to you. And you persevered in the face of even some occasional adversity. And you become very successful. So I just wanted to let you know how proud we are of you at UCSF. And you really are a stellar example of the successful cardiologists that the UCSF training program can create. So congratulations, and again, phenomenal body of work.
Thank you.
All right, so Dr. Redberg, I was able to message me her question. She wanted to say, it's great to see you, Bettina.
Thank you.
And she was hoping you could comment a little more on the gender differences and why you think we may be seeing that difference between men and women.
Yeah, I think what we've seen in COVID-19 and in vaccine-related myocarditis is a percentage that keeps repeating, and it's typically 70-80% men, and that's why we were so interested in looking at our database. And we think that it's hormonal factors that start during puberty that like it has been shown that testosterone can activate immune cells. So we think this plays a role in all types of myocarditis, in the classic myocarditis, but then also in vaccine-related and vaccine-related myocarditis and COVID-19 myocarditis. We still do more research. Actually, we're working with one of the companies of mRNA vaccines to investigate further why men are more prone to vaccine-related myocarditis. And we try to do more molecular analysis on that topic to protect high-risk patients better in the future, because the vaccines are important. So we need to just find better ways to protect individuals from myocarditis.
Dr. Dersenfeld, you had a question?
Fantastic talk, and thank you so much for joining us. I was curious about your thoughts about the data supporting use of immunosuppression, and specifically in COVID myocarditis, where really we don't have any randomized controlled trials of therapies. And that was my first question. And my second question is about the use of T1 and T2 mapping in consideration of early edema and myocarditis.
Yeah, you're absolutely right that there are no randomized controlled trials on immunosuppression in COVID-19 myocarditis. There have been anecdotal case reports and case series. That's the best we have. It does make sense since it behaves similarly to the other types of myocarditis. And if I would have a severe patient with myocarditis in COVID-19, I would give steroids. But this is, of course, anecdotal evidence. And I think T1, T2 mapping is very important and has been shown to increase sensitivity in detecting myocarditis. Not all centers do it, but I very much encourage it, yeah.
And then Dr. Crawford, you had a question?
Yeah, Bettina, great talk. I really enjoyed it. The few cases that I've seen with either COVID or vaccine-related myocarditis have been men, as you pointed out, but they've also been quite athletic. And I wondered if you have any information on whether, being athletic has anything to do with this, and beyond that, what do you tell them? Can they exercise or not while they're recovering from this?
Yeah, that's an excellent point. We've seen this also in athletics, especially, and the hard part is exactly those people you have to tell not to do sports anymore. So this is very hard for them. That's why we've also done a study to see if it's safe to resume exercise after 3 months. It was just a small study, so it's not really powered to fully get the idea. But in general, the recommendation is 3 to 6 months avoiding strenuous exercise. We had done 3 months, and we typically do stress test afterwards, exercise stress test, 24-hour EKG and echo. And if that is all okay after 3 months and they don't have any more symptoms and have recovered, then they can exercise again. The reason why they get more myocarditis, we don't know for sure. It could be that their immune system is more active. There's also this phenomenon of runner's gastritis. I'm thinking maybe there are parallels, that they have just a more active immune system, and that's why they are more prone to get myocarditis. But there's no data on that, why they get it, on the mechanism, but there is data that they have a higher risk.
Great. And then Dr. Goldschlager, you had a question?
I do. Hi, Bettina.
Hi there.
Great to
Good to
see you.
see you. Great to see you.
I'm totally underwhelmed by the use of the ECG here. Now, can you, especially in relation to anything else you would want to do, your recent sentence makes me think, what would be the value? What do you think is the value of the exercise test in these patients?
Well, it has been shown that exercise, or the hypothesis is that exercise can trigger severe arrhythmias in acute myocarditis. And that's why we would do an exercise stress test to see if at peak exercise they develop arrhythmias. The EKG does not have pathognomonic signs for myocarditis. Absolutely agree with you. The EKG can be useful to see if there are conduction defects, because things like giant cell myocarditis or infiltrative diseases like eosinophilic myocarditis can develop severe AV block that needs even temporary pacing. So that's why we still do the EKG, but it doesn't have any pathognomonic changes that can tell us it's myocarditis.
Now, your answer suggests that there may be an adrenergic component to arrhythmia development with exercise. Are you finding that that's true? That would actually surprise me.
Yeah, the hypothesis also comes from autopsy studies from sudden cardiac death, where you find myocarditis in athletes, and we do find patients collapsing during exercise, and then they are diagnosed with myocarditis. So there is a hypothesis that the adrenergic response could cause arrhythmias.
Okay, thank you. And welcome back.
Thank you.
Great. Any other questions from the audience for Dr. Heidecker? Dr. Stang, you have raised your hand.
Hi, Bettina.
Hi
First, let me
there.
congratulate you on your work and also echo what Peter said. We're really proud of you here
Thank
and
you.
help us recruit talented people from Europe over and send them our way. But I had a question for you. I do have a question, which is I was interested in your first study that you presented, which, what is the role of, your understanding of occult myocarditis or low-level smoldering myocarditis that may not be clinically recognized, with chronic viral infections or sequelae, HIV being a good example, potentially.
Yeah, in HIV, the treatment would be the primary treatment of HIV, because the virus is directly cardiotoxic. So there, of course, we also would not give immunosuppression. But in the other cases, often we see patients who have a normal ejection fraction. For example, recently I saw an 18-year-old boy and a man who had an ejection fraction that was normal, but very bothersome symptoms still, severe chest pain that he recently had to lie down on the floor during a city tour because it was so severe. And he had already an MRI half a year ago and another one a year prior. And on MRI, you could see that the late gadolinium enhancement was significantly increasing. And some would not biopsy because you say there's a normal ejection fraction. But if somebody has so severe symptoms and you see that the myocarditis is not healing spontaneously, it's unlikely to heal in a year. So we did a biopsy and there was a lymphocytic myocarditis, and we treated it with immunosuppression, and he was very appreciative and symptoms improved quite rapidly. So when you see LGE is increasing, I really recommend to do endomyocardial biopsy.
Great. And any other questions for Dr. Heidecker? If not, I wanted to thank you once again for your excellent talk. I see
you.
Nora has given you a heart. We appreciate
Thanks.
you spending your time with us today.
Thank you so much for the invitation. It was a great pleasure.